A very good evening. So today's live session will focus on few concepts from your favorite subject, that is oral surgery. The reason why I said it's your favorite subject is no matter whom I inquire, no matter with whom I interact, I hear most of you saying that oral surgery is our favorite topic or favorite subject. And I even hear that most of you who are planning to enter post graduation would prefer oral surgery compared to other specialities. Maybe it's because it gives you a feeling that you are a surgeon, or there can be n number of reasons, passion for surgery, whatnot. So we'll discuss few important topics from oral surgery in the form of multiple choice questions and also in the form of a routine questionnaire, right? So before I start today's session, let me know whether it is streaming fine or not. Also, do confirm this one important thing. Is my audio clear? Or do you want me to raise my voice? So do confirm these two things. We'll proceed with today's discussion. Okay, perfect. Fantastic. So we'll start with that discussion, but before that, I have something to share. So I started reading a new book by Bear Grylls, and it's one of the best books I have ever gone, and I have just placed it here intentionally so that you would see. I'm not trying to promote this, but all I can say is after reading this book, it's a collection of short stories. True Grit by Bear Grylls. So you have plenty of short stories based, these are real life stories which show the potential of humans. I mean, when humans are like, they face extreme situations, what kind of measures they take, they're forced to take in order to survive. So some extraordinary stories, real life stories, and I'm sure it will be very much inspiring if you go through. So whenever you have time, and I definitely suggest you to go through this specific book, True Grit by Bear Grylls. And we'll also have some book reading session from this particular book this coming Sunday. I'll read a short story for you. As I said, a story based on real life events, like how extreme situations bring the best in us. Very inspiring book. So I would like to start with this, and we'll proceed with today's discussion. So as I said, we'll be discussing oral surgery. So we'll go through some concepts, especially pertinent to exodontia, right? Extractions, complications, right? And various protocols to be followed in order to treat specific situations. Yes, exactly. The person whom I'm talking about, you can see his program also, Man vs. Wild, Bear Grylls. Exactly. Anyways, so we'll start with our first question. So you have many complications during extraction or after extraction. I will give you a list of few complications. Let me know what kind of complications or what category they fall under. So you might have heard of two types of complications: perioperative complications and post-operative complications. Fracture of mandible, hemorrhage, nerve injury, oroantral communication. So among these four, which of them is perioperative and which of them is post-operative complications? As you know, we have two types of complications, right? Broadly categorizing complications into perioperative and post-operative. Nerve injury, oroantral communication, hemorrhage, fracture of the mandible. So among these, which are perioperative and which are post-operative complications? Hi everyone. Once again, good evening to all the newcomers, rather latecomers. So I'll repeat the options for you. Nerve injury, oroantral communication, hemorrhage, fracture of mandible. So among these, which are or which is perioperative and which is post-operative complication? Okay, fracture nerve injury, they are post-operative, hemorrhage is perioperative, foreantral fistula is perioperative. Good, good Shivani. Humaira says perioperative is fracture, rest all are post-operative. Wonderful, but I'm really sorry, I tried to pull you in soup. So all the complications which I mentioned now are perioperative complications. Okay? Nerve injury during the time of procedure. There can be injury at that particular instance. When you're extracting impacted teeth, for example, inferior alveolar nerve injury. So nerve injury or antral communication during extraction of maxillary posterior teeth. Don't you think there can be orantral communication then and there itself? It's not post-operative, right? So nerve injury, orantral communication, fracture of mandible, of course fractures, and also hemorrhage. So all of these fall under perioperative complications, right? So is it clear? Okay. So those who are used to my sessions, they know how I try to land you all in soup. But anyways, I'm glad most of you tried answering it. Okay, Ankur, you did not feel bad. You did extremely good. See, participation is more important than getting it right. Yes, Ramya, we're not talking about fistula. Ramya, I clearly mentioned it's oroantral communication. Maybe as you said, fistula, sinus formation, it is time taking, right? But we're talking about oroantral communication, right? It is definitely perioperative. Wonderful. So all the given options which I mentioned now fall under perioperative complications. Just keep that in mind. Or if possible, just have your small customized notes along with you, as I keep maintaining notes for myself. I do have my own notes. So I suggest all of you to have your own notes, prepare notes, revise accordingly, right? So you can just make a note of this point. It hardly takes 2 or 3 minutes simultaneously. Now, we're not talking about nerve injury related complications. We're talking about nerve injury, right? So nerve injury or antral communication, all of these fall under perioperative complications. We're not talking about the consequences of nerve injury, right? Like paralysis or lack of sensations or abnormal sensations, right? We're not talking about the complications. We're talking about the actual organic damage that's happening. Okay, hemorrhage as such falls under perioperative. Now, let me give you a few more options and let me know whether they are perioperative and post-operative. Now let's see how many of you are going to get it right. Trismus, hematoma, ecchymosis, edema, and broken instruments in tissues. So I've given you 5 options. I'll repeat them again. Let me know whether they are perioperative or post-operative. Trismus, hematoma, ecchymosis, edema, broken instrument in the tissues. So which complications do they fall under? Peri or post-operative? Yeah, I'll repeat. Trismus, hematoma, ecchymosis, edema, broken instrument in the tissues. So I see most of Bansi says all are post-operative. Srinita says post-operative. Even Rimi Pandit says the same. Divya, Lakshmi. Yes, Indu, you have a very good question. Secondary and reactionary hemorrhage. Yes. Inquire, refer and do let me know, Indu. That's a very good question. So you're asking secondary and reactionary hemorrhage falls under. Good. Wonderful. So not all are post-operative in what I have mentioned. As you rightly said, trismus, limited mouth opening, accumulation of blood, hematoma, ecchymosis, edema. So all of these are post-operative complications. Wonderful. But broken instruments in tissues is an issue which we'll be facing then and right in that particular situation. So except for broken instrument in tissues, the rest of them fall under post-operative complications. Wonderful. Yes. Yes, Lakshmi. Lakshmi Rajyam, I think you're joining us live. Good. Neha, Sangeeta, Papiya, Elijah. Good. Yes, Shivana. Right. Now, let me give you a few more options and now you decide and let me know which complications they fall under. Soft tissue injuries, displacement of impacted teeth or root tips into maxillary sinus, post-extraction granuloma, infection of wound. I'll repeat these four options once again. Soft tissue injuries, displacement of tooth or root tips into maxillary sinus, infection of wound, post-extraction granuloma. So among these four, which are perioperative and which are post-operative complications? Bansi, Radhika, yes, Riya, Suprati, Diksha, Devangna, Yagna, Somakshi. Good to see you all replying very fast. I'm sure you must be the masters of typing. Exactly. So, infection and post-operative granuloma. It's a post-operative complication. Whereas displacement of tooth into sinus, right? Wonderful. So it is perioperative complication along with soft tissue injuries. Soft tissue injuries, displacements fall under perioperative again, whereas post-operative you have the following. So trismus, hematoma, ecchymosis, edema, as well as infection of wound, post-extraction granuloma. So the name itself indicates that it is a post-operative complication. Okay, let me give you one phrase. Let me know which complication it is. Dislocation of temporomandibular joint. Does it fall under perioperative or post-operative complication? Dislocation of temporomandibular joint. So you're a newcomer, you're trying to extract a maxillary tooth or an impacted mandibular tooth, and you have dislocated a temporomandibular joint. So any fracture, any dislocation, as it is obvious, fall under perioperative complications. So what you're trying to do is list out all perioperative and post-operative complications in your customized notes and try to correlate that with your clinical experience or based on what you have observed or based on what you have heard, right? It will be easy for you to remember rather than blindly by hearting these categories, right? Perioperative or post-operative. So obviously dislocation of temporomandibular joint falls under perioperative complication. Good, wonderful. Now let's move on to the next segment. Now let me ask you one question and I'll give you four options. So let me know which is the most appropriate answer. Which is the best way or most successful way to control soft tissue hemorrhage that involves larger blood vessel? I'll repeat the question. Which is the best way or the most successful way to control soft tissue hemorrhage which involves larger blood vessels? The options include compression, suturing, electrocoagulation, ligation. I'll repeat the options: compression, suturing, electrocoagulation, ligation. So which among the following is more appropriate or the best way to manage or control soft tissue hemorrhage involving larger blood vessel? Yeah, let me repeat the question and option. So, which is the best or most successful way to control soft tissue hemorrhage that involves a larger blood vessel? As I mentioned in 4 options, all of these can be used for controlling hemorrhage. There is no doubt in it. You can use compression forces, you can go with suturing technique, you can go for ligation, electrocoagulation, or you can even go for various pharmacological means, like we have various drugs, right, which are available to control bleeding. So among these various methods, which one do you think is more appropriate answer? No, you have to choose only one option, not two. You can't say compression followed by. Then I'll say everything can be done. All of these can be somehow incorporated. You can compress, you can suture, you can ligate, or if you want, you can even go for electrocoagulation. Choose one best answer. I know you're smart, but I want you to choose one best answer. Okay, I see most of you giving compression. I think you covered all the options. Wonderful. So all of you have covered all the options. So we have 4 schools of thought, because some of you say suturing, some of you say compression, some of you say ligation, and some of you say electrocoagulation. Ligation is right answer. See, we use a hemostat. Assume that this is a larger blood vessel which has been cut. We use a hemostat to clamp it, right? So clamping has to be done initially, and then we ligate the blood vessel, right? Which is considered as the most successful way, the best way among the given options are available to control bleeding, right? Soft tissue hemorrhage, especially due to involvement of larger blood vessel. If it is a smaller blood vessel, then compression would be sufficient, as you rightly mentioned. In question, I clearly mentioned that there is involvement of larger blood vessel. Take for example greater palatine artery, right? Go for ligation. So future oral surgeons would definitely do that, and I'm sure there will be a day where you will come back and say, "Sir, we have discussed this in a live session." I would be happy to hear, and I'm waiting for that day. Smaller vessels, like, you don't need to go for extensive procedures. Just compression, compressive forces are enough, and your body will take care. Electrocoagulation, as few of you said, it's based on current, where you try to generate some heat to coagulate blood. Yeah. It's associated with a bad odor, and also there will be necrosis of tissues, retraction and necrosis of tissues. Good, so ligation is right answer. Well done everyone. Remember, it's not about giving right answer, it's about understanding why it is right answer. So even if you are wrong, it's okay, because now you know what's the right answer, and now you know why we go for ligation. Because even though, in spite of having numerous procedures, if you go by each procedure, if you examine them, dissect each one of them in detail, you'll clearly understand reasons for that. And once you know the reasons behind each option, then it will be much more easier and clear for you. So getting right doesn't matter, but why its right answer is more appropriate, right? So since few of you said it's compression, why do you think, or how do you think compression would actually lead to stoppage of flow of blood? How do you think compression is going to help us in achieving hemostasis? Yes, yes, Lakshmi, you say there is instant control with compression. So how are you achieving this instant control? What do you think is actually happening when you're compressing a particular bleeding site? Hi, Sarita. Yes, Ankur. Application of pressure. So how is it going to help in arresting the bleeding? Yes, Rami, that's true. Whenever there is bleeding, the first thing we need to do is apply compressive forces, apply compression using a gauze. But the question is, which is the best possible way to achieve hemostasis whenever there is soft tissue bleeding with involvement of larger blood vessel? Okay, Ria. See, it doesn't mean that whenever there is bleeding, since ligation has to be done, you don't compress. Compression definitely helps, but the question is, which is the best way through which you can achieve hemostasis? Exactly. Anjali says reconstrict the blood vessel. I'm, I'm waiting for that. I'm waiting for that specific answer. Good, Anjali. Well done, everyone. So, by compressing, you're trying to induce vasoconstriction of capillaries, right? So, there will be vasoconstriction of capillaries leading to decreased flow of blood, finally, stoppage of flow. Exactly. So, compression aims at causing vasoconstriction and decreases the permeability of capillaries. Just keep these two things in mind: vasoconstriction and decreased permeability. Right? Okay. So just make a note of these 2 points, like how compression actually works. And as you said, as Ria said, as most of you said, is compression does help in arresting bleeding in most of these situations. Okay, now I'll give you a description of a specific pathology, identify the pathology, alright, give me the diagnosis based on the hints which I'm giving now. Hint 1, it's an acute infection of soft tissues covering a semi-impacted tooth. I'll repeat, hint 1, it's an acute infection of soft tissues covering the semi-impacted tooth. Second, this is because of injury to operculum, that is covering the unerupted tooth or partially erupted tooth. Hint 3, it presents as a severe pain in the region of affected tooth which radiates to ear, temporomandibular joint and posterior submandibular region. And also it is associated with hint 4, difficulty in mouth opening. So I've given you a few hints: clinical picture, clinical symptoms, and also I've given you the description of this. So identify the pathology based on these hints. I'll repeat. In the meantime, you can answer. Hint 1, it's an acute infection of soft tissues covering a semi-impacted tooth. Hint 2, it could be because of injury to the operculum, that is soft tissues covering that partially erupted tooth. Hint 3, it presents as a severe pain in the area of affected tooth radiating to ear, submandibular region, and also temporomandibular joint. Hint 4, it is associated with limited mouth opening or trismus. If these are not sufficient, I can give you a 5th hint. Now, I've just seen your comments. Almost every one of you have given exactly the same word. I'm sure you're not copy pasting, right? I'm sure you're not. Wonderful. So pericoronitis. So pericoronitis is the right answer. Good. And also it has this characteristic recurrence. Like whenever you go for saltwater gargling or whenever you use some antibiotics, right? It subsides, and then because of accumulation of food or because of pressure from the opposing force, opposing third molar, right? There can be repeated injury, again leading to recurrent inflammation of soft tissues. So basically it is inflammation, infection leading to inflammation, leading to these cyclic changes. Good. So what is the best treatment you can go for? So you have diagnosed a case as a pericoronitis in relation to 3-8 or 4-8. So what's your treatment? Yes, if you extract, you're going to get more money, isn't it? Devanga seems to be smart. She says hot water gargling. Then how are you going to earn, Devang? Exactly. So Ria says extraction in case of recurrent pericoronitis. Devangna says antibiotics. Divya says extraction. Ramya says operculectomy. Even Sandeep says the same. Nahida, Kirti, Srinita, Sakshi. Good. So it's not that you get one exact answer for this. Depending upon the age of the patient, depending upon the timing of the infection, depending upon the recurrence, depending upon the position of tooth, radiographically, clinically, we decide. So operculectomy is something which we can do, but not in the first visit. See, when a patient has come to this specific problem, the first thing you can do is, as Devang has said, just try to diagnose this situation and then advise saltwater gargling. But sometimes even with saltwater gargling, it doesn't subside because of the location of tooth, because of the repeated trauma that's happening. Then operculectomy would be the best thing, and it almost treats or cures this condition. But there are some situations where you feel like the tooth is not in the right position, right? It's angulated differently and it's not going to erupt. There is no chance, it is impacted. Then you can go for extraction. So depending upon the clinical situation, depending upon the status of the patient, age of the patient, position of tooth, so you have various factors and you need to consider this wide range of factors before you decide whether you go advise saltwater gargling or operculectomy or extraction or wait and watch, right? I hope you got my point. Yeah, as far as my knowledge is concerned, and even WHO guidelines clearly say that most of the dental infections do not need antibiotics. We are used to prescribing antibiotics, but antibiotics are not necessary unless and until there is some systemic manifestation. Like for example, this pericoronitis leading to space infections, like, and also systemic manifestations like fever, malaise, then you can go for antibiotics, or else not necessary. I see most of the practitioners blindly prescribing antibiotics just like that without any rationale. But go through WHO guidelines, we are facing a huge problem of antibiotic resistance, and it is in our hands to take care of it, right? So antibiotics are not necessary in all situations. In fact, even during our post-graduation, almost 99% of the times for endodontic infections, we never prescribed antibiotics. Our HOD was totally against that. He taught us some concepts, and the best thing we used to do is, for soft tissue related inflammations, saltwater gargling works wonders. It's not that trying to find means to squeeze patient, but it's about giving the best qualitative treatment to the patient, isn't it? So with experience, you'll definitely learn many things, and we were taught that antibiotics are not necessary in all cases, and it's literally our experience that we never prescribed antibiotics in almost 99% of the cases. Because if you're doing root canal treatment, if you're going for access opening, that itself will help you in draining the infection, right? Simple techniques like saltwater gargling, right? All this will definitely help in controlling the infection. In fact, it's not that we are great and we're doing something fantastic. Body has this natural resiliency to fight any kind of infection, to take care of its own infection in the form of inflammation. So it is body's tremendous response that we're trying to tap into. Okay, and you need any further information pertaining to antibiotic prescription and all, you can refer WHO website. Have plenty of information. Also, there are several PubMed indexed articles explaining you why you shouldn't randomly prescribe antibiotics for most of the dental infections. Take my word. Yes, yes, Ankita. Even operculectomy. So it's not that if even after operculectomy, if you think that there is soft tissue hyperplasia, then you need to go for definitive measures like extraction. Yes, Ankur says we need to provide pain relief first in clinical practice. But Ankur, and antibiotics, the purpose is not to relieve pain. We have analgesics for that purpose. You can prescribe analgesics. And if we are looking for short-term benefit, then we are in fact hurting our patient and hurting our community on the long run. Antibiotic resistance is a worldwide problem. So you can just check out WHO website. It's not me saying, it's WHO saying, World Health Organization. And if you're looking into short-term gains like satisfying the patient because of their ignorance, then it's nothing but our ignorance, isn't it? That's why I said, don't take my word. Go through the literature and then get back for discussion. I'll be happy to discuss with you. Right? So we'll move on to the next question. Exactly. The reason I have elaborated on this specific topic for a bit longer time is I'm really frustrated at this. I see most of the practitioners, I know I can't say everyone, but as far as my observation is concerned, I see most of them blindly prescribing antibiotics without any proper rationale behind the prescription. Okay. Let's move on to the next question. So, you said edema is a post-operative complication. Very good. So let me ask you one related question. In case there is edema after extraction, take for example impaction, you might have experienced edema or you might have seen patients experiencing edema. So edema is associated with swelling. So this swelling reaches a maximum size within how much time? And it begins to subside within how much time? So I'm asking you the time duration. So when does the swelling reach to the maximum size and when does it start regressing or subsiding? Any idea? Wonderful. So Lakshmi says within 2 days. Pandit says 48 to 72 hours. Exactly. Good. So the maximum size or the maximum swelling can be seen 48 to 72 hours. That is 2 to 3 days after the procedure. And then usually from the procedure, 4 to 5 days after the procedure, there will be regression in the size. You might have experienced it in your clinical practice or in your college. Yeah, 48 to 72 hours, we can see we have a specific time limit. It's not that we have a timer and exactly after 48 hours or 24 hours, the swelling reaches maximum size. So, depending upon the body's response, maximum size, swelling reaches maximum within 48 to 72 hours after the surgical procedure and begins to subside on 3rd or 4th day post-operatively. Do make a note of these 2 points, right? Okay, so let me ask you one question pertaining to instruments. So next time I'll see if I can arrange a monitor so that I can project you some instruments for image-based discussion, right? I'll try. So this question is pertaining to instruments. So which periosteal elevator is most commonly used in oral surgery? I'm not going to give you any options. I mean, if you give me right answer, that's fine. If you don't, then I want you to refer and get back through mail for discussion. So which periosteal elevator in intraoral surgery is most commonly used? Yeah, it's mucoperiosteal elevator. Periosteal elevator, yes, we're talking about mucoperiosteal elevator. So let me reframe the question. Which mucoperiosteal elevator is most commonly used in oral surgery? Himanshi says molds number 9. Ayushi says mold 9. Divya says straight elevator. Okay, straight or curved, you are naming it based on the working portion. Can you give me the number? Ankita, I'm not talking about regressing of swelling in 48 to 72 hours. It's not about acute or chronic. We're talking about swelling which is an acute phase. So maximum size of swelling in 48 to 72 hours and it starts regressing in less than a week. That is 4 to 5 days post-operatively. Okay, so a few of you got it right. Mold 9, number 9 elevator. Exactly. So the most commonly used periosteal elevator intraoral oral surgery is number 9 mold. So it has two ends. One is a pointed end, you might have seen it, pointed end. It is used for elevating interdental papilla of gingiva, and there is a broad end which is helpful for reflecting your mucoperiosteum. So you might have seen your straight elevator which has a pointed end on one side and a broad end on the other. So broad end is for reflecting the soft tissues, elevating mucoperiosteum, whereas the narrower end or the pointed end is for dealing with or elevating interdental papilla of gingiva, right? Wonderful. Okay, now let me talk about BP blade. What does BP stand for? By the way, that's not the question. I have the question coming up, but before that, what does BP in BP blade stand for? I mean, the reason why it's called as BP blade is the moment you look at it, you'll start having BP. So, is that right? So, in fact, this question, one of my seniors asked me this question when I was in final year. No, I think I was in second year. Then he asked me to find out. I took 2 days, but I couldn't find out because nowhere in literature I could search for this term or the short form of BP. And he said Beard and Parker. So from then onwards, I had this Beard and Parker in mind. But later, during my PG prep, I realized that it's not Beard, it's Bart. Bart Parker. And you guys are really lucky and sharp that you have the right word at a very young age. Congratulations. Okay, Bart Parker. Exactly. Now the question is, yes, Bart Parker. So we have different types of BP blades. So most commonly used, we have 3 types, number 11, 12 and 15. So among these, which is the most common one that is used? The most commonly used number? Among number 11, number 12, number 15. So I'm giving you 3 options. Wonderful. So it is number 15, intraoral surgeries. Now let me ask you another question. Which is the most commonly used handle, BP handle? I mean, you can number it. Which is the most commonly used BP handle in oral surgery? Wonderful again. So, Kirti, Ramya, Himanshi, Lakshmi, Anusha, Srinita, Pandit, Suprati, Mahida, Rakshita, Christina, Akila, Rohit. Lakshmi Rajam, so you say you're getting answers before the question starts. So it is a very good sign. It shows the enthusiasm of this discussion. So it's a very good sign. So you can see the positivity of enthusiasm is it is contagious, right? Isn't it? Exactly. So do make a note of these points who haven't heard of these things prior. So the most commonly used BP handle is number 3. The most commonly used BP blade is number 15. Wonderful. So as you know, 15 is used for flaps and incisions on edentulous alveolar ridges. So where do you use number 12 and where do you use number 11 BP blades? Number 12 and number 11. Yes. Wonderful. So number 11 is for stab incisions, for smaller incisions, good. So number 12 is indicated for incisions in gingival sulcus and incisions posterior to the teeth, especially in the tuberosity area, maxillary tuberosity area. Whereas number 11 is used for small incisions, right? For example, you're incising an abscess. So you can go for BP blade number 11. Yes, yes, Devangana. Good. Okay, let me ask you one basic question. What are the parts of an extraction forceps? You have seen plenty of extraction forceps. What are the parts of extraction forceps? Yes, Supratim, we do use these three types of blades commonly in oral surgery. Yes, so the parts as you have mentioned, so we have a handle, we have a hinge, right? Not a shank, but we say hinge. And then we have a beak, right? So we have a handle, we have a hinge, and then we have a beak, isn't it? I don't have any here. Okay, fine. So the question now is, during extraction, pressure is applied on which of the following parts of extraction forceps? During extraction, pressure is applied on which of the following parts of extraction forceps? So you said beaks, hinge, handle. So where do you apply pressure during extraction of a tooth? Seems to be a very easy question. Then I should expect only the right answer. Exactly. See, during our initial days, we try to exert more pressure on beak or hinge area, but lever and fulcrum principle. So it's on the handle. When you apply adequate amount of pressure, it's not about the amount of force you're using, but it's about the technique, as they say. So the right amount of pressure applied on handle makes extraction very easy, right? So handle is right answer. It's not hinge, it's not beak. Okay. So instrument is held by handle, and when proper amount of pressure is applied on handle, then we go for extraction. So let me ask you another related question. So among these three parts, you said handle, beak, and then you have this hinge. Which is the functional component of the extraction forceps? So among these three, which is considered as functional component? So among these three parts, handle, hinge, and beak, which is considered as functional component? It's a pretty straightforward question. So functional component is actually which is in function, which is nothing but your beak, isn't it? So I hope you got the concept right. So we have these three components. So we think that what's there to know in this, but once you go into depth, the basics are very important, right? So pressure is applied on the handle, and beaks are considered as functional components of your instrument, right? So just keep these points in mind. And today I posted some morning questions, 5 a.m. questions. So I'll go through those questions once again, but I'm not going to reveal answers. I want you to inquire, refer, and let me know. Okay, and then we'll stop with these questions. So the first one, during extraction of tooth, which of the following is true? Listen to this carefully because the words which I am using are very important. So during extraction of tooth, which of the following is true? The angle between dental chair and the floor is 120 degrees in case of maxilla. The angle between dental chair and the floor is 110 degrees in case of mandible. Both the statements are true. Now, so I'll repeat the question once again for you. I would like to hear from you. Okay, do you want me to reveal the answers? Because I actually plan to give you the key tomorrow morning. If you want me to let me know the answers, I can. Today's 5 a.m. question answers. It's up to you. Yes, we all want to know the answers, which is a very good sign. So, I'll repeat the question once again and then we'll also try to hear from the other members who are live and then we will let you know the answer. I'll let you know the answer. During extraction of tooth, which of the following is true? The angle between dental chair and the floor is 120 degrees in case of maxilla. Option B, the angle between dental chair and floor is 110 degrees in case of mandible. Option C, both. Option D, none. In fact, when I posted today morning, I haven't mentioned option B as in case of mandible, right? I mean, I just lost it because it was early in the morning, I just lost it. I'm sorry. So option B is angle between dental chair and floor is 110 degrees in case of mandible, 120 degrees in case of maxilla. So now let me know which is right answer. Yes, both the statements are true, right? So during extraction of tooth, the angle between dental chair and the floor is 120 degrees in case of maxilla and 110 degrees in case of mandible. Okay. Tomorrow I'll post you an image in the study club discussion before we start our 5 a.m. session questions. You will have a better understanding. Okay. Next one, Chomprey elevators. I'll just spell that word here so that it will be easy for you to follow. I mean, to those who haven't followed today's questions. So you can see in the comments section now, Chomprey elevators. They are used for exposing destroyed teeth, to remove roots, to remove broken root tips, to reflect gingiva around an intact tooth. So which one do you think is the right answer? I'll repeat the question. Chomprey elevators, they are used for extracting destroyed teeth, to remove roots, to remove broken root tips, to reflect gingiva around an intact tooth. Yes, Srinitha says it's used for reflecting gingiva. You are able to reflect gingiva using these Chomprey elevators, and because of which you are able to expose any destroyed teeth and also you are able to extract root tips or any fractured fragments, right? So all of the above is right answer. So do make a note of this point. So these all fall under the uses of Chomprey elevators. So Chomprey elevators are used for exposing destroyed teeth, reflecting gingiva around an intact tooth, remove broken root tips, remove roots. All of the above is right answer. Now let's move on to the third one. While extracting mandibular anterior teeth, dentist A right-handed dentist is placed in front and to right of the patient, behind and to right of the patient, both, none. So it's based on operator and chair positions. While extracting mandibular anterior teeth, right-handed dentist is placed in front and to the right of patient, behind and to right of patient, both of the above and none. Because I've seen both ways of positions being practiced, and also literature suggests the same. So both of the above is right answer. You can either sit in front, stand in front, extract, or you can sit or go behind and then right to the patient. Obviously you have to be on the right side of the patient. You are right-handed operator. Exactly, Sangeeta, good point. So both of the above is right answer. So in extracting mandibular anterior teeth, right-handed dentist is placed in front or behind and to the right of the patient. Okay, find the false statement. Very interesting one, and it has a greater clinical significance. Find the false statement. Option A, during extraction of deciduous teeth, forceps used is small and has narrow beaks. Option B, beak of forceps are positioned on mesial or distal area of deciduous tooth. Option C, beaks of forceps are positioned in such a way to engage root bifurcation as the crowns of deciduous tooth are delicate and can fracture easily. Option D, none of the above. So among the given options, find the false statement. I'll repeat option A. During extraction of deciduous teeth, forceps used is small and has narrow beaks. Option B, beaks of forceps are positioned on mesial or distal area of deciduous teeth. Option C, beaks of forceps are positioned in such a way to engage root bifurcation as the crowns of deciduous teeth are delicate and can fracture easily. Option D, none of the above. So which option do you think is more appropriate? So during extraction of deciduous teeth, forceps used are small and has narrow beaks because the crowns are delicate, smaller comparatively. So option A is right statement. Option B, beaks of forceps are positioned on mesial or distal area of deciduous tooth. Option C, beaks of forceps are positioned in the root bifurcation area. See, if you observe option C, I tried to intentionally trap you by giving you some unrelated, non-relevant explanation. In fact, engaging root bifurcation would lead to even extraction of the permanent counterpart, permanent tooth bud. So never ever engage root bifurcation areas of deciduous tooth. That's very, very important. So in order to avoid this, we either engage mesial or distal aspect of the tooth to prevent this extraction, unwanted extraction of tooth bud to happen, right? To avoid root bifurcation area. I hope you got my point. So beaks of forceps are positioned on mesial or distal area of deciduous tooth is right statement, whereas option C is false. Beaks of forceps are positioned in such a way to engage root bifurcation. We never engage root bifurcation because of fear of extraction of the successor permanent tooth bud, isn't it? So I hope the explanation is satisfactory, right? So because most of you I see have chosen option D or option B, so is it persuasive? So is it acceptable now? Yes, Akila, why not B? B is a true statement. We engage mesial or distal areas but not root bifurcation areas. For the very same reason which I mentioned now. We are trying to avoid root furcation area. Okay, I see Lakshmi Rajam crying, but see, you need not cry. See, we're all in a learning phase. There is nothing wrong in giving wrong answers. So the more wrong or mistakes you commit, the more learning happens, which is a very good sign. But provided you are positive and oriented. If you are demotivated and depressed, then everything goes the opposite way. So final question, assertion and reason. We'll stop with this particular question. So assertion, double angled elevators are used to extract root tips in maxilla or mandible. I'll repeat the assertion. Double angled elevators are used to extract root tips in maxilla or mandible. Reason, sharp tips of elevators easily fit between root tip and alveolar bone. Reason, sharp tips of elevator easily fit between root tip and alveolar bone. So you might have seen these double angled elevators. So double angled elevators are used to extract root tips in maxilla or mandible because sharp tips of elevators easily fit between root tip and alveolar bone. So is it justifying? So do you think both assertion and reason are true? Also let me know whether reason justifies assertion or not. Exactly. So both the given statements are true and reason justifies assertion. Wonderful. So these are some of the questions which I wanted to discuss. So I actually wanted to discuss morning 5 a.m. questions tomorrow, but since we had this oral surgery live session, so I felt that it's relevant to fit these questions here. So anyways, I'm sure you got your answers, and if you have any further questions, you can always get back through mail, right? So before I conclude, so I hope you found this session informative. So the best thing you can always do is have your own customized notes. Do not rely on guides or other sources of notes for your revision. So have your own notes, even if it is now. See, it's never too late to start your preparation. Even if it is now, it's the best time to start making your notes, right? So you have attended this live session. I'm sure you can make out at least 15, 20 or maximum 25 depending upon your ability. Some 25 key points. So all of this can be considered as important things and which you can revise especially during your revision time. And once you go through these topics, go through these important points, you will have that sense of confidence and satisfaction which is far more important than actually gaining information. See, no matter how much information we gain, if we are not confident, then it's all gone. So what's important is confidence building. And one of the confidence building measure is to prepare your notes, and that's the reason why I keep on repeatedly telling you almost the same thing almost in every session. So we need to build up confidence by various techniques, and notes preparation is one of the best ways of confidence building. Take my word. Right? So I hope you got my point, and if any one of you are feeling demotivated, feeling depressed, assuming that you're not getting right answers, you're feeling like everything is new, take my word, if you're making mistakes, if you're finding everything new, if you're feeling like you're learning new things, it's a very, very good sign. Provided, as I mentioned prior, if you're positive and oriented, you're going to take it as an opportunity and move forward with lots and lots of determination to learn and give your best. But if you're demotivated and depressed, it will be the opposite, just the opposite. You feel like giving up, you feel like, no, there is still a lot to learn, so let me just give up, because you see yourself as a loser. So I personally see that we all have two options at any given situation: either move forward with positivity and determination, or just stay there or move or go behind and then try to hide away from all the challenges. So it's up to us to decide which path we choose. It's as simple as that. So it doesn't matter if you're wrong, it doesn't matter if you're feeling that everything is new, it doesn't matter if you're feeling like you're learning new things now rather than your undergraduation time. It's never too late, take my word. So consider this as an opportunity. In fact, when you're having these kind of feelings, it's a very good thing because you're concerned. See, only when you're concerned about something, right, you have those kind of feelings. Like it can be stress, it can be tension, or it can be anxiety or whatever. So having these feelings is a good sign that you are concerned about yourself and your preparation. Keep it aside, keep that concern with you, but eliminate all these kind of negative feelings and just focus on giving your best, right? So anyways, you have any queries or any concerns, you can always get back through mail 24/7, and as I keep on saying, I'm just a mail away. So wish you all the best, love you all. And if you have anything to say, you can just leave it in the comment section. I'll go through it and I'll get back to you. Okay? So I'll give you an example. I'm talking about two situations at any given instance. See, you can see that whenever you go across any video, you have some likes and dislikes. How many of you think that having a dislike for your video is a bad thing? Assume that you've done a video, or let's say I'm doing this live session, I have some dislike, or it can be right now I have one dislike, maybe I'll have 2 dislikes or 3 dislikes. How many of you think that it's a bad thing to have a dislike to your video? So imagine yourself in my position. So how do you see it? See, we can't say we can ignore it, because when you have likes, you feel good. But when you have dislikes, how do you take it? First of all, it doesn't matter. That's the first thing, because if you go based on likes and dislikes of other people, then you can never do things which you really love. You shouldn't rely on others' opinion or others' feelings for what you're doing. And the first best answer I got is from Humaira, and I completely agree. It shouldn't matter for you, the first thing. And second thing, even if you think that you should consider it, it's a very good sign. If you have a dislike, it means it is a challenge, as Kirti rightly said, as Akila rightly pointed out. So it's a chance for you to improvise. If at all you feel like there is some lack, based on the feedback you get or based on your perception. So first thing, it doesn't matter. And second thing, if you want to consider the same, you'll see that as an opportunity to improve. I mean, if it is all lovely and wonderful, then where's all the fun? So it's all matter of perception. I'm telling you, take my word, it's all matter of perception. So others' feelings should not influence you. That's the first important thing. And second thing, even though if you feel like you should consider it positively. You take it as a challenge and make sure that you give your best. But in spite of doing all of this, there will be some people who will dislike what you do. So how are you going to address it? Don't address it. That's how you're going to address it. See, we are going to address certain things by not addressing them. That's the irony. I hope you got my point, right? So no matter what you do, it doesn't matter. Some people will dislike you. The best way to address those kind of situations or instances is by not addressing them. In other words, ignoring them. So you should know what exactly you have to do, right? So I hope you got my point. So that's the best example I've got in order to explain you how you take things. It's all matter of perception. It's how you perceive. It's not about what others say, it's about how you perceive. No, I didn't quote this example with an intention to increase the number of likes. It's up to you. You can dislike it. As I said, I have my own strategies to handle dislikes. Right. So it was really fantastic interacting with all of you, and it's your active participation which makes all of this very much possible. So see you again in another live session, and I'm going to read out a short story, inspiring story about human potential this coming Sunday, and I'm sure we're going to enjoy that session. Looking forward to hear from you all. Love. Take care. Hi Ajaj, we're just concluding the session. Yeah. Anyways, I'm glad you joined us. Bye. Good night, everyone.